This is a case study presented by Chyna, Coleman, and Jessica Stenis. Our patient, called Dimitre, is referred to occupational therapy following a distal radial ulnar fracture to his right upper extremity. A distal radial ulnar fracture occurs when there is a break in both the radius and ulna bones of the forearm. An orthopedist or MD will need to realign the bones for healing. This is called a reduction. If surgery is required, this is referred to as open reduction, but if no surgery is required, this is called a closed reduction. Dimitre's case was a closed reduction. Fractures are also classified by the type of break as viewed on an X-ray. Standard treatment for closed reduction requires casting to immobilize the joint as the bones heal. As swelling of the site goes down, the cast may be replaced and the site cleaned. Casts will usually be removed for good after 6 weeks. Because each break is different, recovery and rehabilitation varies from patient to patient. The leading cause of wrist fractures are falls. Symptoms include pain, swelling, bruising, deformity, and the inability to put pressure or weight on the joint or bone. Possible complications that may occur following wrist fractures are stiffness, reduced range of motion, arthritis due to poor articular congruency from incorrect healing, nerve compression leading to carpal tunnel syndrome, and muscle contracture. Some precautions to consider during treatment are that pain during therapy is a negative sign, because you may cause further injury to the area. The OT must be careful to monitor the patient for signs of pain, as it can be very easy to be too aggressive during the early stages of therapy. Also, use physical agent modalities with caution. During rehabilitation, the patient might see an OT, PT, or certified hand therapist. Some of the most common expected outcomes are for individuals to return to normal function, although each injury is unique. Many people will have wrist stiffness for 1 to 2 months following cast removal. It is recommended that clients return to light activities in 1 to 2 months after cast removal and heavy activities 3 to 6 months after cast removal. Full recovery can take up to 1 year, as bone healing may take several years. And some people may have stiffness and aching that occurs for up to 2 years, especially for people older than 50, those who received high-energy injuries or comorbidities such as osteoarthritis. Standard interventions for fractures during the rehabilitation phase. One of the first priorities is to control any edema. This can be achieved by elevating the affected area above the heart, performing manual edema mobilization, and through continuing movement of the area. Pain management is also important. It can usually be controlled through over-the-counter medications such as ibuprofen or a prescription from the doctor. Physical agent modalities of heat and ice can be applied to reduce edema or pain. Scar management may be needed using desensitization or compression. Splints may also be prescribed by the physician to continue to provide support or act in a protective manner to the affected area. Block certain motion of the joints, maintain functional positions, or help restore certain movements, as with a volar wrist orthosis, which would help restore wrist extension. Therapeutic exercises will be done during therapy with the goal to remediate muscles and joints surrounding the injury site using controlled movements. Examples are range of motion at the injured and adjacent joints, strengthening to both intrinsic and extrinsic muscles, grasp and release exercises, endurance building, and motor control exercises. A home exercise plan will be given for the client to continue after formal therapy. Evidence shows that early mobilization of an upper extremity orthopedic injury via range of motion is shown to be effective in decreasing pain and swelling and aids in returning clients to previous levels of function and occupation. Following these types of preparatory treatments, function-based activities will be performed. Activities of daily living retraining may be done so the client can be functional during the healing process, and in the case that there is a complication and they cannot regain prior level of function and independence. This is achieved through compensatory strategies using adaptive devices, task modification, or environmental modification. It is important to keep in mind that protocols for rehabilitation will be based upon stability of the fracture and fracture management. The treating physician will dictate the protocol of rehabilitation.
Who is Dmitri? Dmitri is a 92-year-old Russian man, widowed with 2 sons. One of his sons is deceased from a heart attack, and the other one he moved all the way to this country 20 years ago to live closer to, and he is diagnosed with Parkinson's disease and lives in a nursing home. He also lives alone in a first-floor apartment with his pet bird, who he takes care of daily. He calls this bird his family and frequently have conversations with it. He does not drive, but he likes to walk. He often visits the neighborhood grocery store to buy milk, vegetables, and fruit. Dmitri relies on a volunteer service to take him to see his son in a nursing home. Prior to his fall in his bathroom, he was fully independent. Medical history. Dimitri's medical history consists of he has non-insulin dependent diabetes, congestive heart failure, cataracts, which the left cataract was removed, but the right could not because of macular degeneration, which means his vision is pretty poor in his right eye due to the cataract. And also he has a history of alcohol abuse. Dimitri's injury consists of him falling in his bathroom and ended up fracturing the right distal radius and the ulna. It was a clean break and there was no surgery required, but he had to wear a full arm cast in elbow flexion for 6 weeks. And recently the cast was removed and now he's receiving assessments. As the OT, we have generated a list of assessments to use during evaluation with Dmitri. We're going to assess areas such as range of motion, edema, strength, coordination, sensation, cognition, ADL function, IADL function, as well as upper extremity function. We're going to use assessments such as goniometer measurements, observation, manual muscle testing, pinch and grip strength testing, light touch, sharp, dull, hot, cold sensation, the mini mental status exam for cognition, and most importantly, we're using the DASH self-report assessment. It's called, it stands for Disabilities of the Arm, Shoulder, and Hand. And through that, we can find ADL function, IADL function, as well as upper extremity function. And it's all dependent on self-report and observation.
Now we will outline Dimitri's current level of occupational performance when occupational therapy treatment begins. Dimitre has no perceptual deficits and has intact cognition except for his memory. This affects his ability to remember to take his medications. Although this is not a direct result of the fracture, it is important for his healing and recovery.
For sensation, Dimitri's evaluation demonstrated that he had decreased sensation for sharp dull in his right upper extremity. He also complained of numbness and tingling as well in his right hand and fingers. Through this evaluation, we see that he had decreased sensation, which will be something we will need to work on.
Most of Dimitri's occupational performance issues are motor-based. Strength testing revealed that his left upper extremity is a 4 out of 5 throughout, which is functional. His right upper extremity varies, with shoulder movements a 4 out of 5 and elbow and wrist a 3- out of 5. His active range of motion is within functional limits in his left upper extremity, but his right upper extremity has deficits. Elbow extension was negative 25 degrees, wrist flexion 20 degrees, wrist extension 15 degrees, and fingers can only do 1/3 the full range of motion. Dimitre also has impairments in gross motor coordination, fine motor coordination, and dexterity on his right side. He reports pain during wrist movements, and his wrist and fingers present with edema.
For his current occupational performance with ADLs, his current functional status in ADLs include showering with moderate assistance, dressing is minimum assistance, but he is still unable to tie his shoes and have difficulties with fasteners. His transfers are independent, as well as his ambulation is modified independent using a cane, which he uses now with his left hand now that he has injured his right hand, which is his dominant hand.
Dimitri's performance in IADLs are affected by his injury. He reports difficulty with meal preparation, cleaning tasks, laundry, and caring for his pet bird. Also, due to his decreased memory, he has trouble managing his medications.
Following the determination of causes of problem, we have developed a list of areas of occupation affected. The first area is his ADL functioning, which encompasses his showering, his dressing, his inability to tie his shoes, and his ambulation using a non-dominant hand. Another area is his IADL functioning, as we mentioned before, his home management and maintenance in reference to his meal preparation, cleaning, pet care, and medication management. Another area of occupation we are concerned about is his social participation. It's not directly affected by his fracture, but his refusal of help from neighbors, him not having any friends or family, and him not liking to ask for help can be detrimental to his healing process and recovery.
The causes of Dimitri's problems in each domain of occupational therapy. Client factors affecting Dimitre are body function, of impaired sensory function, and pain limiting his movements. Neuromusculoskeletal and movement-related functions. Fractures affecting joint mobility, joint stability, muscle tone, and muscle power. Dimitre also has decreased endurance due to immobilization while casted. Values. Because Dimitre does not like to ask for help and is an independent person, he is having to do everything for himself, even though his neighbor has offered to help. This causes Dimitre frustration because he can't do everything at prior level of function. Performance skills. Motor and praxis skills. Dimitre has deficits in coordination and manipulative skills, contributing to his problems. Sensory perceptual skills. Numbness and tingling in the right upper extremity are related to the fracture. Performance patterns. Dimitri's habits have been interrupted by adapting to restrictions of his right hand during immobilization and using his left hand to compensate. He now uses his cane in his left hand rather than the right, as done pre-injury. Dimitre has had to adapt his routines by using his left hand and is currently unable to complete tasks independently. Dimitri's identified roles are widower, parent, pet owner, and Russian. Context and environment. His cultural context is his Russian heritage and that he walks daily. Personal, he is 92-year-old male, Russian, has other medical conditions previously discussed, and he does not drive. Temporal context. He is in a late stage in life and has lived in the U.S. for 20 years. Physical. He lives alone on a ground floor apartment. Occupational therapy occurs in this home. He takes walks around his neighborhood and he walks to the neighborhood market. Social. He receives occasional help from a neighbor. His pet bird is his family, and he says that they have conversations. He is widowed and his son lives in a nursing home, so he has few chances to visit. He interacts with volunteers from senior services who take him to the grocery store and sometimes to the nursing home to visit his son. Activity demands. The activity demands of Dimitri's occupations. The objects and their properties. Dimitre ambulates with his cane, which, again, he previously used with his right hand. He must manipulate clothing for dressing and while doing laundry. He uses kitchen tools and food supplies for meal preparation, which he must manipulate using both upper extremities. Cleaning agents and tools, bathing items, and pet care items. He must open and close the cage, interact with his bird, give the bird food, and clean the cage. Social demands. Occasionally he visits his son and is driven by the senior service volunteers. Otherwise, he has no social contact. Dimitre does not speak English very well or like to ask for help. He has no family besides his bird. Sequence and timing. He has to remember steps for dressing, bathing, meal preparation, his laundry, cleaning, medication management, and pet care tasks. Dimitre does have a memory issue with his medication. Required actions and performance skills. Dimitri's motor and praxis skills are decreased due to the fracture and for his right upper extremity being immobilized in a cast for 6 weeks. He has numbness and tingling in his right hand and fingers and impaired sharp dual sensation that may contribute to his difficulty with fine motor and manipulation skills. Required body functions. Neuromuscular skeletal functions including mobility of joints, strength, and sensory functions required for ADLs and IADLs are deficient due to the fracture. Required body structures. The radial ulnar fracture has impacted Dimitri's nervous system, skin, sensory processing, and structures related to movement.
Frames of reference. The 2 frames of reference we chose was biomechanical and rehabilitative. Our primary one is biomechanical because it directly guides musculoskeletal disorders, which is a fracture. It helps restore the body functions and structures of the client. And with its biomechanical principles, we can apply these principles to restore Dimitri's right upper extremity function. Now, secondary, we chose rehabilitative because in case he can't restore all his function, because it may take longer to heal due to his age, or he may not regain all prior level of functioning, we will provide Dimitre with compensatory techniques to regain his independence. Intervention approaches. Our intervention approaches consist of establish and restore because we want to restore Dimitri's right upper extremity function, range of motion, strength, and coordination. We also want to adapt and modify and provide Dimitre with adaptive equipment or modify tasks and environments during his healing and if his structures or functions cannot be restored. And lastly, we want prevention. We want to prevent any further deficits or any further issues to develop secondary to his injury. Now to goals and outcomes of OT intervention. His first long-term goal is ADL focus goal. Dimitre will complete self-care activities independently over 2 consecutive sessions by discharge. His short-term goals consist of 1. Dimitre will independently zip his flax during 3 consecutive sessions in 2 weeks. 2. Dimitre will independently button his shirt during 3 consecutive sessions in 3 weeks. And 3. Dimitre will improve showering from moderate assistance to modified independence in 3 weeks. For his second long-term goal, this is more of an IADL focused goal. Dimitre will demonstrate independence in home management activities by discharge. His short-term goals consist of 1. Dimitre will complete a full basket of laundry consisting of 15 pieces of face towels independently in 2 weeks. 2. Dimitre will complete a meal preparation activity for feeding his pet bird for 3 consecutive sessions within 2 weeks. And 3. Dimitre will demonstrate washing dishes independently by completing a sink of 10 plates, cups, and utensils, varying in size and shape, within 3 weeks. With these goals, we will then develop intervention activities.
Treatment activities, which are preparatory in nature, will be done with Dimitre. Range of motion exercises at the elbow, wrist, forearm, and fingers will help Dimitre increase his functional range of motion and thus increase his independence in activities and occupations. This intervention can be graded by beginning with passive range of motion and advancing to active range of motion. It can also gradually increase the number of exercises and joints involved. The second preparatory intervention is strengthening of the right upper extremity. These exercises can be graded by using putty and tools with various levels of resistance, such as TheraBands and Gripmaster tools of different colors indicating the different level of resistance. Both range of motion and strengthening are needed to restore the integrity of joints and muscles affected by the fracture. Without joint mobility and muscular strength, Dimitre cannot perform his occupations.
Intervention Activity 1 for long-term goal 1, the ADL focus goal. Dimitre will practice dressing with the occupational therapist. He will do activities such as buttoning his shirt, zipping jackets or pants, donning and donning off socks, or tying shoes. The rationale behind this activity is that it's a functional activity that Dimitre will need to do every day, and working on it will help him become more independent in performing this task. By providing adaptive tools as needed, Dimitre could be successful and independent in dressing. Grading can be accomplished by using different sizes of buttons, beginning with large buttons and working towards smaller ones, and utilizing his button hook, his adaptive tool, to complete the task.
For long-term goal 2, targeting Dimitre's IADLs, we will engage him in a grasp and release task of folding laundry. This is recommended by Cynthia Cooper in Occupational Therapy for Dysfunction as a way to retrain biomechanically efficient movements and avoid movement pattern substitutions. Laundry is also a functional activity that Dimitre needs to do weekly. It can be graded and practiced for strengthening and endurance of Dimitri's right upper extremity. The activity may begin with only a few towels of similar size and then made more difficult by having various clothing in the basket. This grades the task up by providing increasingly challenging movements with a variety of motions. Dimitre will have to adjust to the different sizes of clothing or towels as well.
Service delivery. Service will most likely be provided by the occupational therapist within the home, primarily in his kitchen or bedroom or living room, but there may be some instances where we go out into the community to his neighborhood market. The frequency of service will be 1-hour sessions 3 times a week for 4 weeks. We found that this time will give him ample amount of time to regain as much function as he can. Dimitri's discharge plan is to continue living in his first floor apartment independently. However, we do have recommendations for the future. We want Dimitri to continue his home exercise program to further increase his range of motion and strength in his right upper extremity. We also want to advise him to ask neighbors for help when needed to prevent any further injuries. And lastly, we want to help him find community resources for social participation and for more reliable transportation. Thank you for listening.